Okay, without further ado, we'll start the webinar today. So just a massive thank you for everyone for joining this lunchtime webinar. We really do hope it'll be a useful hour out of your really extremely busy days. The webinar is being delivered in partnership between Royal College of Pathologists and our corporate member, Illumina. We'd like to thank them for their support and involvement. My name is Sian Morgan. I'm a consultant clinical scientist and laboratory director of the Always Medical Genomics Service. I'm also chair of the RCPath Genomics and Reproductive Science Speciality Advisory Committee, as well as the outgoing chair for RCPath NECWAP in Genomics. Our speakers today are Dr. Pilar Ramos and Dr. Magdalena Meissner. Dr. Ramos is a senior manager in the Illumina Europe Medical Affairs team. She leads educational initiatives and collaborations with key opinion leaders to support the adoption of comprehensive genomic sequencing in cancer diagnostic. Dr. Meissner is a medical oncology consultant at the Velindre Cancer Centre in Cardiff and holds the position of a clinical senior lecturer at Cardiff University. She also serves as the clinical liquid biopsy lead at the All Wales Medical Genomics Laboratory. There will be time at the end for Dr. Ramos and Dr. Meissner to answer your questions, so please do add those questions into the Q&A box. We will try and cover as many as we can. So over to you, Dr. Ramos.
Many thanks, Sian. I will be sharing my screen. Fantastic. Many thanks, Sian, for the nice introduction, and good afternoon, everyone, and thank you for joining us. So I will be presenting an introduction to the exciting and evolving field of ctDNA-based liquid biopsy testing, which is proving to be a powerful tool in precision oncology. Despite the promise of precision medicine, up to 30% of patients are missing out on its benefits because there isn't always enough tissue available for next-generation sequencing profiling. This is especially problematic in some cancers like non-small cell lung cancer, biliary tract, and prostate cancers, among others, where obtaining sufficient high-quality tissue can be particularly difficult. And factors that influence tissue insufficiency include the biopsy technique that is used, the tumor content, and whether tissue has already been consumed by prior tests. All of these can limit what's left for sequencing. And the impact can be significant. When we can't get a full molecular profile, we risk making treatment decisions with incomplete information. And that's a gap that we need to close. Now let's talk about circulating tumor DNA, or ctDNA. This is DNA that comes directly from tumor cells undergoing necrosis or apoptosis, and that is released into the bloodstream. It typically accounts for less than 1% of all the cell-free DNA in the blood, and yet it can be incredibly valuable for diagnostic and prognostic purposes. Liquid biopsy analysis, in its broader term, refers to the analysis of tumor-derived material, which can be DNA, RNA, circulating tumor cells, or exosomes that can be found in bodily fluids, not only in blood, but also in CSF, urine, or saliva. But in today's session, we're focusing mainly on the analysis of ctDNA in blood. Now, liquid biopsies can be used to analyze a wide range of genomic alterations, including mutations, chromosomal rearrangements, copy number alterations, even epigenetic markers like DNA methylation, using the same NGS-based techniques that we use for tissue testing. ctDNA analysis can be applied along the entire cancer continuum, from early diagnosis and treatment selection to detecting minimal residual disease, monitoring treatment response, and identifying relapse. Now, while tissue biopsy remains the gold standard for biomarker testing, it has limitations. It involves an invasive procedure. It captures just a single moment in the tumor's evolution and often has longer turnaround times. Liquid biopsy, on the other hand, is less invasive, allows for serial testing, and can better reflect tumor heterogeneity. But it is not without its limitations. So let's look briefly at some of these advantages and limitations of liquid testing. As you well know, tumors most often consist of different clones, both within a single tumor and across multiple metastatic sites. And what's powerful about ctDNA analysis in this context is that it can better capture the full complexity of a patient's single or multi-tumor disease, since it can pick up the mixture of tumor DNA fragments being shed from all active tumor sites, giving us a broader view than a single tissue biopsy ever could. One challenge of ctDNA testing is clonal hematopoiesis. This is a common aging process where blood cells acquire mutations, especially in some selected genes, as the ones shown here. And these mutations can be mistaken for tumor-derived alterations. There are some approaches that are being already utilized to overcome this limitation, including advanced bioinformatic pipelines and the use of matched white blood cell sequencing to distinguish clonal hematopoiesis-related mutations from true tumor variants. Another challenge is that ctDNA levels vary based on tumor type, burden, disease stage, and even sample timing. So not all patients are ideal candidates for liquid biopsy at all times. And proper sample handling and assay sensitivity are critical for accurate detection. Indeed, various studies, like the one here from Hussein et al., have shown that ctDNA detection rates vary widely across tumor types. Tumors like colorectal, prostate, cancers of unknown primary, breast, and lung shed more ctDNA and are more likely to be detected, while others, like here on the right-hand side of the graph, pancreatic, cholangiocarcinomas, or ovarian cancers, have been shown to shed less and are thus harder to detect via liquid biopsy. ctDNA levels also tend to increase with disease progression, so that metastatic and late-stage tumors shed more ctDNA, making them more detectable than in stable disease. Important also is the timing of testing, as ctDNA levels can fluctuate with treatment. For example, while a sharp decline is observed following surgery, as one would expect, radiation may cause a temporary spike. So it is important to understand these dynamics to help us optimize when to collect samples for the most informative results. The proportion of ctDNA relative to the total amount of cell-free DNA in the blood, what we call tumor fraction, is also important to consider when testing for some genomic alterations, for example, for CMVs and genomic signatures like microsatellite instability, or MSI, as detection of this type of alterations requires higher tumor fractions, while short variants and fusions can be detected at lower levels. Higher ctDNA fractions, depicted here in orange, also correlate with better sensitivity and specificity. And because of this, when ctDNA levels are low, negative results should generally be confirmed by tissue biopsy testing. However, methods to quantify ctDNA are improving, and we might get to a point where we can be confident of a negative result. Currently, ctDNA fraction is most often calculated using bioinformatic algorithms, but there is a lack of standardization and robust processes for reliable interpretations at this time. Here's an example of a case that illustrates how liquid biopsy can detect emerging resistance mutations and provide a broader picture than tissue biopsy alone. So this is a published case of a 53-year-old male with metastatic BRAF V600E colorectal cancer, who was treated with a combination of EGFR, BRAF and PI3 kinase inhibitors for about 16 months before experiencing tumor progression. Biopsy of a progressing liver lesion revealed the original BRAF V600E mutation and an emergent KRAS G12S mutation. Post-progression ctDNA analysis by comprehensive genomic profiling showed not only the original BRAF V600E and the emergent KRAS G12S mutations, but also an NRAS Q61R and a low-level EGFR amplification, all known resistance mechanisms of BRAF V600E colorectal cancer. All three resistance alterations identified in the ctDNA were identified in at least one of the additional post-progression tumor samples, but no single tissue biopsy harbored all alterations. And this highlights the power of ctDNA testing for the detection of emerging resistance alterations to help guide treatment. So to summarize, ctDNA-based liquid biopsy is a transformative, non-invasive diagnostic tool that can enable precision oncology. It enables dynamic and comprehensive genomic profiling across the cancer continuum, and often with shorter turnaround times. While not without limitations, it holds great clinical value potential. As evidence of the clinical utility of this diagnostic method accrues, clinical guidelines are increasingly recommending the use of ctDNA testing to complement and overcome some of the limitations of tissue biopsy profiling. For example, the ESMO guidelines now recommend liquid biopsy for biomarker profiling in multiple tumor types, especially when tissue is unavailable or rapid turnaround is needed. Thank you for your attention. With that, I'm pleased to pass the baton over to Dr. Magdalena Meissner, who will share insights from the QuicDNA study in Wales. Over to you, Dr. Meissner.
Thank you, Pilar. So I will talk to you now today about implementation of liquid biopsy into lung cancer diagnostic pathway, and I want to share with you about the QuicDNA study, which has been ongoing in Wales. This is my disclosures, and I will now go on and talk to you about the current situation in Wales regarding lung cancer. Before I talk to you about the study, I want to give you a little bit of background why we actually decided to implement liquid biopsies into lung cancer diagnostic pathways. So lung cancer is the fourth most common cancer in Wales and is the leading cause of cancer deaths. As you can see on this chart, that we've got different stages of cancer, stage 1, stage 2, 3, and 4. But most patients, unfortunately, most patients in Wales are diagnosed at the stage 3 and 4. And as you can see, this orange line drops significantly in patients with the stage 4 disease. So 1 year survival for stage 4 disease is about 15%. So there is, we've got very poor outcomes compared to the rest of the UK and Europe. However, as you know, there has been great development in genomic biomarkers and targeted therapies in lung cancer, and now we have potentially up to 70% actionable mutations in lung cancer, and some of them already receiving treatment in first-line settings. There are plenty now emerging new mutations and new treatments. We actually can probably say every year or every 6 months there's something new coming up on National Test Directory for biomarkers now we need to test. And now we have more than 10 biomarkers on National Test Directory where we have to test for those patients. And just starting with very early clinical trials when they were comparing, starting with EGFR mutated lung cancer, starting with gefitinib, already showing improvement in progression and overall survival for patients compared to placebo. There were then further studies showing improvement even compared to chemotherapy or immunotherapy. There's also another biomarker like NTRK fusion and lorlatinib being used and showing great responses for multiple tumor types. So since 2003, there has been rapid accelerations of drug development and approvals by FDA and EMA for targeted therapies in non-small cell lung cancer. I have to say, I remember when I was a registrar, we only had few chemotherapies to offer patients, and that was really depressing. But now, and as you can see, there are many targeted therapies and newer generation of existing therapies, so they even perform better than the older generation of specific targeted therapies. So as Medical Oncology Society now recommends, and as the specific guidelines for us to test patients with stage 4 disease for all these mutations before actually patient is considered for treatment, because this patients, once they are allocated to the right treatment, they have much better survival and much better benefit for these patients. So we've got this brilliant discovery of genomics and brilliant discovery of treatments. However, our patients, the lung cancer patients, they are very fragile, and then actually they can, when they present, they can be unwell already, and they can deteriorate rapidly and die if treatment is not received in time. And as you know about the 62-day NHS target, which is a pathway when from the cancer suspicion by GP, or whether it's on the CT scan, to the first treatment, date of the first treatment. Unfortunately, even less than 50% patients getting a treatment within 62 days. There are a lot of patients still going beyond 62 days. And actually, we think this 62 days is too long for those patients. They need to be diagnosed faster to be able to receive the right treatment at the right time. So we thought there is a critical need to improve and shorten the diagnostic pathways. And we thought that this can be done by introducing liquid biopsies. So I'm sure you're very familiar with the diagnostic pathways, but just to try to visualize and simplify this diagnostic pathway to show you where we actually introduce the liquid biopsies in this pathway. So as you can see, you all very know this pathway very well, but also you can see the tissue molecular testing comes quite late in the pathway, even if it's reflex testing. And the results can take quite a long time to get to the patients, and patients sometimes can wait and go beyond the 62 days before they get the treatment. So what we're suggesting and what we've done in a QuicDNA study. So as soon as patient has been referred by a GP, or as patient been admitted via hospital and had a CT scan that showed suspected stage 3, stage 4 lung cancer, then these patients often are reviewed by a respiratory team. And this team will plan their diagnostic procedures, whether it's tissue biopsy by bronchoscopy or CT-guided biopsy. But what we ask them to do is to take the blood sample before even tissue biopsy is planned, and send this blood sample to Allwell's Genomics Laboratory, where we applied a TSO 500 gene next-generation sequencing panel, and we provide the all molecular profiling for that very important meeting, MDT, where now not only imaging and histology can be reviewed, but also genomic profiling can be assessed as well at the same time. So the MDT team has more information about patient tumor type, and they can arrange potentially quicker oncology points, especially when the biomarker has been identified. And the oncologist can plan actually treatment potentially within the same day or the next day, because often these targeted therapies are oral therapies. Therefore, we can actually start them quicker than chemotherapy or immunotherapy. So our primary objectives for this QuicDNA study was to integrate liquid biopsies in the pathway, shorten time to treatment compared to the standard of care pathways, and also increase the number of patients that receive targeted therapy. We know that the tissue are the issue in lung cancer, and some patients can have to have multiple tissue biopsy to get them to the genomic profiling results. And sometimes that time is taking too long, and by the time they have results, they're often too unwell, or sometimes die before they actually can get the treatment. And by shortening diagnostic pathway, we can improve patient outcomes. We also have secondary endpoints, very important endpoints as well, where we compare time to report for tissue and for liquid biopsies. We also want to make sure that our concordance is high between liquid biopsies and tissue biopsies in detection of multiple actionable variants. And also we're looking at patient outcomes. So patients treated based on liquid biopsy, they are follow-up. We want to make sure if they're responding to treatment and what is their overall survival. We're also hoping that with this approach, we can reduce repeat tissue biopsies. When often the genomic profiling is available, there's no need to repeat another tissue biopsy. And we're also assessing cost effectiveness of this approach by doing health economic assessment. So Allworld Genomics Laboratory has introduced comprehensive genomic profiling with 500 gene panel as a sort of first genomic hub collaborating with Illumina, and launched this tissue panel in August 2021, and already great stories for patients who have been detected biomarkers. And in 2023, in April 2023, we've launched QuicDNA study, and we offer patients liquid biopsies at suspicion of stage 3 and stage 4 disease. We've opened this study in all health boards in Wales, to all patients have that possibility and opportunity to be tested. We wanted to demonstrate feasibility of this in lung cancer, and aiming to use this knowledge to expand to other tumor types in future. And by doing this as a research study, we are allowing ourselves and using in-house tests. We are actually generating a lot of data, also collecting additional samples, allowing us to use those samples to work on other technologies as well, and develop our own research. We actually have a PhD in labs in our lab now, and also happy to share with other researchers as well. So far, we've recruited actually 600 patients for the study, and we've detected with liquid biopsy these variants here, like KRAS variant, EGFR, MET exon 14 skipping, BRAF, ALK fusion, and RET fusion with liquid biopsies, and patients being treated based on these results. So I wanted to show you some early results from our study from 113 patients. Just to show you that this sort of table shows you that we've detected all patients actually had, because this was being done very early in the pathway. We have confirmed non-small cell lung cancer, we had small cell lung cancer, we have other cancer types, and there's also a small number of patients who did not have cancer, and also a very interesting group of patients who actually could not have tissue diagnosis, and they were classified as a radiological lung cancer. And also these patients, as you can see, we've detected mutations. So looking at this, the top row shows you the actionable variant detection in ctDNA, and we've detected 24, which is more than we detected in the tissue, which we had 18. And the lower bar shows you how many patients actually received treatment. 11 patients received treatment based on the ctDNA, and 2 patients based on tissue results, as there was ctDNA not available for this patient. And on this slide, on the lower part of the slide, you've got a breakdown of what type of mutations we have identified in these patients. And as you can see, still some patients, even though they have mutations confirmed in both tissue and liquid, still not receive treatment. Whether this is because patient deteriorated still quite quickly and unable to be treated is still maybe something we need to work on. And also showing very high concordance for patients who had tissue available and ctDNA available. We had very high concordance of 98%. As I presented this study, one primary endpoint was time to treatment. So from the day 0 of the diagnostic pathway, from the GP referral or CT scan to the time when actually treatment was started. We have 11 patients who actually been treated based on ctDNA. And as you can see, the pink bar is showing you the ctDNA median time from the diagnostic pathway to treatment was 45 days. And we only had those 2 patients and only had tissue results. And unfortunately, one patient started treatment at 66 days and the other one 116. So as you can see, it takes quite a long time if we only have tissue results for them to start treatment. And on the right side, there is average, actually a median time to start treatment for all patients that have started treatment in this cohort. As you can see, it's not 62 days, it's actually median time was 74.5 days. And also to briefly tell you as well about time to report from sample collection on the left, and on the right is from time of day 0 of the diagnostic pathway. So as you can see on the top, liquid biopsy, ctDNA, median time was 14 days. Unfortunately, with tissue, it was almost twice as much, 26 days to wait for the results, genomic results. And also in terms of looking at the diagnostic pathway, because the also sample was collected early in the diagnostic pathway, the results were, we were able to provide within a median time 24 days. And unfortunately, with tissue, it took us about 3 weeks longer to provide similar results. So now I want to show you the video of a patient who had 3 tissue biopsies, and unfortunately none of them were able to give us a histological diagnosis, and also there was no enough material left to actually perform any genomic profiling. But this patient had ctDNA and BRAF mutation was detected. And I want to now share with you this patient's story. And I hope you can hear the sound.
Now, lung cancer kills more people than any other form of cancer, with around 1,900 deaths a year in Wales. It is not the most common cancer, but part of the reason it has such a devastating effect is that it is often diagnosed at a late stage. Well, there are hopes that a new blood test that looks for tiny fragments of cancer DNA could lead to quicker diagnosis and better treatment. Our health correspondent, Owain Clark, has the story.
I'm very well, thank you. Yourself?
Checking in for his latest checkup. But last winter, Phil Marks from Cogan was so ill, he feared not reaching his 62nd birthday.
Wasn't eating, couldn't eat. And I actually said to my partner, take me to hospital. Otherwise, I'm not going to be here next week. And that's how bad I felt.
Phil already knew he had cancer, but doctors were struggling to find out its exact type. That's until the result of a new blood test came through, and Phil was put on new tablets.
From not being able to eat half a pasta meal, pig meal, I woke up on a Sunday morning and my partner said, well, what do you want to do? And I said, how about a carvery? She just burst into tears. Bless her.
The test Phil had is now available to anybody in Wales thought of having lung cancer which has grown or spread. But how does it work? Usually doctors try to find out more about someone's cancer by physically taking out tumour cells from the body, but these biopsies can be invasive and difficult. But as cancer cells grow and multiply, they release tiny bits of their DNA into the bloodstream. Patients give a simple blood sample, which is analysed by sophisticated machines that look for and read these fragments. Then, by knowing a cancer's genetic code, doctors can choose what treatment might work best.
So it's not only important to know whether there is actually cancer there and what stage it is, but it's actually important to know what biomarker this cancer have. And now patients, when they are treated, they have more than 10 treatment options in first-line settings. That means as soon as they're diagnosed, you have a cancer, you can start treatment with targeted therapy.
The rugby community has got behind us massively.
The rollout was made possible in no small part because of the efforts of this former rugby director, whose cancer developed before the test was available. Doctors became concerned about Craig Maxwell shortly before his 40th birthday. It took almost 3 months to find out he had inoperable lung and bone cancer.
We had to wait 78 days for my diagnosis. And when you've got limited time left, if somebody had said to me, here's 50 days back to spend with your family because you were in a better psychological state, I'd give anything for those 50 days back.
Craig then learnt new tests could speed things up for others. So by organising and taking part in several challenges, set about raising the extra £300,000 the team needed to deliver them. He's gone on to raise a staggering £1.5 million.
What he's done has been absolutely incredible.
What I've done is run and cycle and climb mountains and talk about they've done the hard work, but being part of that team, that means that if somebody like me walked into hospital tomorrow knowing that there's a a test that could benefit them, then I've been a small part of helping that. By far the proudest thing I've ever achieved.
Experts are now looking at how these tests might be used to detect other cancer types and eventually used as screening tests, which could revolutionise cancer care. But they also warn about wider challenges.
Patients are waiting too long. The demand is currently outstripping that capacity we have, and mostly that's workforce and machines, and we need more of those. But we also need to do more with what we do have.
But the new test certainly offers hope, not least for patients like Philip Marks.
I never thought I'd pick up a golf club again. I never thought I'd go on holiday with my family. And I've been able to do both.
He'll be forever grateful of the precious extra time he's had with family and friends.
So that's the video of Philip, and this study has attracted a lot of attention now in media, and also, as you might be aware as well, and also in England recently was also announced that now this liquid biopsy test, ctDNA test for suspected stage 3 and stage 4 lung cancer has been added to the National Test Directory, and now we are in the process of transforming the study now into the standard of care pathways and optimizing pathways and working how can this be incorporated into the standard diagnostic pathways. So, but we don't want to stop there. We know that building on this, what we already achieved in QuicDNA and lung cancer, we want to also build on that and give this opportunity to other patients with other tumor types. Therefore, now we're working on the setting up the next study, which will be called QuicDNA Max, and we will hopefully be starting hopefully this year. And I will thank you for everyone who was involved. With army of people working behind this, and this was great collaboration between NHS, academia, industry, and patients to help us deliver this study. Thank you, and I will now pass back to Sian.
Thank you, Magda, for a brilliant presentation, and also to Dr. Ramos as well. So there are questions coming in. So without further ado, we'll start with the questions and see what kind of answers we can give to these questions. So the first question here is, are ctDNA results uploaded onto your LIMS system so that they are accessible to pathologists and molecular clinical scientists? Magda, do you want to take that one, or oh, you're on mute. You're on mute.
Sorry, yes, so our results from the liquid biopsy are uploaded to our Welsh Clinical Portal, which is available to all clinicians in Wales. So all the oncologists, pathologists can review the results. And the MDT teams as well. We also separately email the results as well. I don't know, Sian, you want to add anything?
No, that is perfect. So next question is, with the introduction of lung cancer screening and more tumours detected at a very early stage, what do you think is the long-term role of ctDNA? It's a great question.
Yes, that's a good question. So there are different sort of technologies and liquid biopsy. So for ctDNA, currently the technology we use is mainly dedicated to advanced disease, stage 3, stage 4, as Pilar has mentioned about how the ctDNA is shedded by tumors. There is potentially future role, but there's still so many companies already and researchers working on the screening test with the ctDNA and other tumor biomarkers, but we still need a lot of validation in that setting.
I'm just thinking, Pilar, would you like to respond to that question as well from a manufacturer perspective?
Yes, yeah, I completely agree with Magda. So yeah, the use of testing of liquid biopsy testing can be applied along the different time points along the cancer pathway. And so the QuicDNA study is looking at profiling patients who have already a disease, in this case lung cancer, versus testing for detecting the potential development of in this case a cancer early. And these are different types of tests, and that require different types of sensitivities and even technologies. And so the most advanced indication or application of liquid biopsy testing at this point is for the stage where, a disease, in this case, cancer has already developed, and here we can use liquid biopsy testing to identify the molecular drivers and to help us guide treatment. And this is where things have developed the fastest, and then the other points of the cancer pathway are a bit behind, but coming up strong, including the early detection point.
Thank you, Pilar. So the next question is, are ctDNA results comparable with ADILA results, which also look for actionable mutations? I don't know. Is it either Magda or Pilar wants to take that question?
Pilar, do you want to start?
Sure. This is the ADILA question. Yeah. Okay. So ctDNA testing can be performed with different techniques, and so there are a number of commercially available tests that you can use. And even if we're talking about NGS, so next generation sequencing profiling of ctDNA, you can use from a small targeted panel of just 2 or 3 genes, which is what ADILA panel does. This is a company that makes these small targeted tests, to a large comprehensive genomic profile that tests 200 to 500 genes. So there are different types of tests that you can use. So ADILA is just one example of a method of testing ctDNA.
Magda,
I'm not sure it's much for me to add, but yes, so the test we are using is 500 gene panel, and I think reviewing this sort of ctDNA with more comprehensive profiling gives us opportunity to look not only the actionable mutations which are currently actionable, but actually also in future looking at trial mutations or more, other actionable mutations which will come in future. So it's constantly revalidating. Adding new genes can be quite problematic for laboratories. So if we have the actually test that can provide it with results for multiple tumor types, and it's just basically unblocking the bioinformatic pipeline, it's a much, I think, more comprehensive, more cost-effective, and more clinically valuable.
So the next question, what is the data available for the use of ctDNA for diagnostic purposes? Has it been used to determine the type of tumour? Also, have there been instances where mutations have been detected by liquid biopsy but have been negative on tissue? So shall we take that in 2 stages? Do you want to answer the last one first? Because I think that's a really key question to the data that's been presented today by you, Magda. Has there been instances where mutations have been detected by liquid biopsy but have been negative on tissue?
Yes, so there's been incidences like this, and actually for patients specifically, the ones I've showed you as well about the radical lung cancer, radiological lung cancer patients when tissue was not available, or patients refused to have tissue biopsy performed, or patients have multiple biopsies, but none of them has produced genomic results. So, or sometimes we have negative results, even if there was full quality, and patients was able to be treated based on the ctDNA results only and still have a good outcome from the treatment. So that's definitely possible. And that's what ESMO guidelines dictates now, that patients who cannot have the tissue and have positive liquid biopsy tests, they should be starting treatments.
So just to add to that as well, Magda, so for any cases where we have detected a biomarker on liquid biopsy, has there been any cases where the genomic profile in the tissue did not detect that?
Actually, most patients in our study, when we had good quality results, actually we had 98% concordance that we haven't. So all patients we had positive, we actually were able to confirm on the tissue. If there was incidents when we couldn't, there was most of the time there was missing tissue testing.
Thank you, Magda. So going back to that first part of the question, so what is the data available for the use of ctDNA for diagnostic purposes, and has it been used to determine the type of tumour? Do you want me to split that too?
Yeah, so, I don't know whether Pilar wants to take a little bit of that. Yeah.
Okay. So what is the data available for the use of ctDNA for diagnostic purposes? I think Magda's already shared that it's already on the test directory, so would have gone through that evaluation pipeline. And Magda, you presented the ESMO guidelines.
That's
so I
right.
think I'm going to turn to Pilar. There might not be, but are there any other data available for the use of ctDNA for diagnostic purposes? So are there any other large studies ongoing, perhaps in Europe, that absolutely shows the use of ctDNA in a diagnostic pathway?
Yes, I think you're definitely with QuicDNA at the forefront of that specific type of generation of that specific type of data. There are many studies looking at evaluating, the detection of alterations across different cancer types. There are large clinical studies like NCI Match in the US, and many of them drug-like studies across Europe looking at identifying targetable alterations that can be used for guiding the treatment of cancer patients. And most often it can be in the context of a clinical trial, in the context of being introduced into the cancer pathway. I think UK is definitely at the forefront.
So I can just add quickly as well, there's been Lubil trial as well, and which is similar to QuicDNA, but a randomized trial. There's also been Canadian trials as well, and US trials confirming use of ctDNA for in lung cancer patients.
So just to go back then quickly to Pilar. So what you're basically saying, there's a huge variation on the adoption of liquid biopsy that you see across Europe?
Indeed, yes. Yeah, even though, ESMO and other guidelines are, increasingly recommending the use of liquid biopsy, it is, we can say, is still at early stages of adoption into routine, but it's definitely growing,
So the last question then, has it been used to determine the type of tumour? And this can go to either Magda or Pilar. Magda?
So we have to be actually quite clear here. So when we're analyzing genomic biomarkers for the patients, so not necessarily we are detecting type of cancer. So that's potentially another step of looking at different technologies and methylation technologies when we can predict a histological subtype. But from the NGS we are performing at the moment, we only are concentrating on finding the specific actionable mutation biomarkers. Sometimes it can help, especially when there's unknown primary cancers and you identify EGFR mutation that may be suggesting more about being lung cancer origin, but that's something in still development.
Okay, so there's lots of questions coming through, so I'm going to try and rattle through some of them now. This is a really great question as well. So great presentations, Pilar and Magda, thank you. If tissue is still required for PD-L1, does this still delay the treatment time, waiting for PD-L1, even when you have the ctDNA result that has detected the mutation, or does treatment commence without the PD-L1 result? Let's do that one first.
That's a very good question, and we actually had that situation in our study. So the PD-L1 still has to be tested via tissue, but you don't have to wait for these results. If you have identified biomarker in ctDNA, patients still will be better off starting the targeted therapy than immunotherapy. So you don't need to wait for the PD-L1 results. That might be useful for the future.
So aligned to that, does treatment for a mutation demonstrate more effective results than immunotherapy?
Yes, this patient definitely do better. That's why it's important for them to start in first-line settings, targeted therapy, not chemo or immunotherapy, and avoid any delays. Because in the past, we had to wait for the results, all of the results, and sometimes as a clinicians, we were starting chemotherapy or immunotherapy before we had the genomic results, but that was apparently very wrong approach. And now we need to sort of, it's been evidence-based that patient needs to start on the right treatment at the start.
And this is the last question on this, but definitely follows what we've just discussed. Also, does treatment of mutations prior to immunotherapy benefit the patient or make the immunotherapy less effective? So also, does treatment of mutations prior to immunotherapy benefit the patient or make the immunotherapy less effective?
So there's been studies that prove that this sort of targeted therapy, when you have specific actionable biomarker, is better than immunotherapy. You can then still treat patients once they progress in the second or third line with immunotherapy, but they often do respond. The response is not as great, and there are also now more data coming up about mutations that can suggest response or resistant to immunotherapy as well, which hopefully will be added on shortly as well to our pipelines as well, to identify those patients who might benefit or not. As you know, the PD-L1 may not always be the best predictor of immunotherapy response.
Yeah, there's been a lot of data on this important question, and it has shown that the order of the treatments really does matter, and it is important to start with the kinase inhibitors first. Otherwise, immunotherapy will be less effective down the road.
So this is a question that either one of you can answer as well. Is it possible to correlate biopsies to the ctDNA levels to understand disease progression? Do you want me to repeat that? Is it possible to correlate biopsies to the ctDNA levels to understand disease progression?
I'm not sure where I'm understanding the question. Is the disease so we are collecting another tissue biopsy at the time of progression? Or because normally what we would do, they would have tissue at the diagnosis, and we can do longitudinal samples with ctDNA at the time of progression. You can also do tissue biopsies as well, and with that, you can correlate. And there's been lots of study with correlation, and often as sort of Pilar presented in her presentation, the case when we actually could detect more resistant mutations from the blood rather than from the tissue. So I don't know if that answered the question.
I think you have, Magda. So this is a really good question for you, Magda. So what merit is there in testing both ctDNA and tissue simultaneously if both were available at the same time? So I suppose you can discuss some of the conversations at the moment that's happening in Wales.
So it's
the optimal pathway.
Yeah, I think the pathway. So looking at the pathway, we actually can take blood sample quite early, much quicker than as soon as patient have suspected stage 3-4 lung cancer on the scan, you can send the blood sample straight away. Not with the tissue biopsy, you still have to plan it and book patient time for bronchoscopy or for the CT guided biopsy. So it's not sort of so I think from that point of view, sample collection, we can still deliver the results with ctDNA much quicker. And also, if it happens that we have both, actually the ctDNA advantage would be that can capture that heterogeneity, which Pilar mentioned. We might either, if we have a tissue biopsy, we might only have at one point in time one's place from the tissue, which might only present one mutation, but actually patients might have multiple mutations. And we know now from lots of different sources, and also what I've studied, and there are more researchers studying, there are coexistent mutations, and that can potentially affect patients' response to treatments. It's not just one mutation important, but actually sometimes the coexistent markers, which will have prognostic biomarkers, can be very important for our treatment, for delivering patients treatments, or how we manage patients in clinic with that. So I think there'll still be some advantages of adding ctDNA, even if we have results at the same time.
So are we at a place, Magda, where we can consider stopping tissue testing? And the second part, or should we stop tissue testing if you've got a result on ctDNA?
So I want to make sure we're clear about tissue testing. Histology is still important. So we're not stopping histological testing, but if we have, we potentially can stop genomic tissue testing. So when we detect ctDNA biomarker, specific biomarker, and we know that we have high concordance, and then the tissue more likely will produce the same result, in that situation, we could potentially stop tissue genomic testing, but not histological testing.
Thank you. So this is another one. Do you think this will reduce the need for biopsy? I'm just thinking of, we've seen Mr. Marks in that video, Magda, whether you can say a little bit more about his journey and what mutation he found, etc., and the treatment.
Yeah. So this patient, so just an example of Mark, yes, so he had ctDNA and he had a BRAF mutation detected, but they were still trying to find sort of the histological diagnosis for the patient, whether there was sarcoma, lymphoma, lung, multiple different tumor types they were going through, but the patient was deteriorating, and eventually his oncologist had to decide what to do, and he becoming so unwell that he was not fit for chemotherapy or immunotherapy, but he could still offer him the targeted therapy. So that's how the decision was made, that to treat patient on the ctDNA, and potentially now when we have more evidence, they could have stopped the next 2 tissue biopsies. They could have just stopped at the first biopsy, which was inconclusive, and try to treat him based on that ctDNA. Maybe a little bit sooner, rather than waiting and do more tissue. And I hope, and I think we're probably able to at least reduce repeat tissue biopsies that will potentially, just for the genomic purposes, because often as we know, clinicians need to get that genomic testing, the results quite quickly for the clinic. If we can shorten that time by stop repeating those tissue biopsies, if we have already ctDNA results, that hopefully that will be beneficial to patients. But I want to say that the histological diagnosis is still important if possible.
Thank you, Magda. So this is going back to your data again, and I think it's really important for us to be able to describe the data you presented today. So this result is saying, what is the frequency of the false negative results? Have you encountered any discrepancies with tissue-based DNA testing? So the question is, have we not detected anything on a ctDNA test, but we picked it up on tissue?
So I think that we had 2 patients on that data when we detected on tissue, but not on ctDNA. But the reason was actually that the ctDNA also can fail. So it's not just the tissue can fail, but also ctDNA does. We did our tissue sort of rate as sort of 3%. But if the test was good in terms of the tumor fraction having a good amount of DNA, we had 100% concordance. The only we had this concordance when the actual or tissue failed or actually ctDNA failed.
And I think that's a really, really important point, that when we had a biomarker result, both for ctDNA and tissue, we had 100% concordance.
That's right.
Magda.
Yeah.
Excellent. So can ctDNA be used as a marker of disease monitoring in early stage cancer after their first? It doesn't complete. Shall I ask Pilar to answer that, Magda, to give you a breather? So Pilar, can ctDNA be used as a biomarker of disease monitoring in early stage cancers?
Early stage. So yeah, they're evolving techniques that are still far at this point, or in the early stages of being introduced for the detection of, as we mentioned, of a cancer. But once a cancer has been detected and diagnosed, the ctDNA labels can indeed be used to monitor the progression of the cancer and the treatment response.
Thank you, Pilar. This is for Magda, has this study only focused on peripheral blood so far as the liquid biopsy of choice?
So at the moment, yes, blood at the moment, but there, as sort of Pilar has mentioned in her presentation, there are other potential liquids we can test, which is urine, pleural fluid, saliva, and there's others. I think for some tumor types, some other, apart from blood fluids, we could potentially use, and there's lots of research already ongoing in that field, and potentially there is something coming to clinics soon as well.
Yeah, if I may add, yeah, the genomic profiling protocols are more developed and advanced for blood, but indeed there are,
I think
new
that
developments.
now, for example, urine is now the next one, I think, to come, especially for sort of urological cancer, when maybe the urine testing might be better than a blood test, but it's still early days to say.
So this is really important as well for us as part of our study. How ctDNA differs from NGS in terms of number of genes tested. Pilar, perhaps this one for you. So how many genes do we test on the 500 tissue, and how many genes do we test on the liquid, and is there complete concordance with the genes we're testing between both assays?
So in this, there's a lot of flexibility, just like there is for tissue genomic testing. You can test from a couple genes to doing a more comprehensive analysis, like it's been done in QuicDNA. And so for QuicDNA, where you're doing both tissue and liquid, you are indeed covering the same, almost nearly 100% the same genes on both sides. So you can then really compare.
Thank you, Pilar. I'm just mindful it's 13:27, so this I think will have to be the last question. It would be great for anaplastic thyroid cancer, as tissue is very limited most of the time and tumour is fatal with rapid deterioration. Is BRAF V600 available for ctDNA? That can be for either. Magda?
So yeah, we can detect BRAF V6 in ctDNA. The patient we presented in our video had that mutation, but as again, that sort of type of thyroid, you can potentially perform the test. The only thing, the caveat is that we know the thyroid cancer from, as Pilar's slide, they do shed less ctDNA to the bloodstream. But if patient is unwell, if nothing to lose, just you can do test, and if it's a good tumor fraction and there is detection of BRAF60, the patient can be treated based on that result.
So thank you, Pilar, and thank you, Magda, for really inspiring talks this afternoon on liquid biopsy. And thank you for all the questions that have come through and everyone who's taken the time today to join this webinar. We really hope you found this worthwhile. We will be emailing everyone a feedback form. Please do fill it in, as it will help shape our programme of educational webinars within the Royal College. We will also circulate a recording of the webinar, which will be uploaded to the college YouTube channel. I wish everyone a great afternoon, and many thanks for joining us on this webinar today. Thank you, everyone.